Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily. These experts provide their opinions, insights, and commentary on the leading topics and issues in medicine, focusing on specific disease states. Today, I'm joined by three national experts, and we will be discussing anemia and myelodysplastic syndrome, or MDS. First, we have Dr. Andrew Bruner from Mass General Cancer Center. Dr. Bruner, would you like to introduce yourself?
Hi, it's great to be here today. My name is Andy Bruner. I'm from Mass General Cancer Center up in Boston, Massachusetts. I primarily treat patients with MDS. And, I'm really excited about the new options that we have in treating this disease. We have an expanding number of ways to approach anemia in these patients.
Fantastic. And next we have Dr. Rami Kamrachi at Moffitt Cancer Center. Dr. Kamrachi, would you like to introduce yourself as well?
Hi, I'm Rami Kamrachi from Moffitt in Tampa, and also it's my pleasure to be here and echo Andrew's excitement about the changing landscape and what we call like 2022-23 is the breakthrough year in lower risk MDS with positive clinical trials. So I'm glad to be here discussing that.
Very, very good. And last but certainly not least, we have Dr. Guillermo Garcia-Manero at MD Anderson Cancer Center. Dr. Garcia-Manero, please introduce yourself as well.
Thank you. So I'm very happy to be here with Dr. Brunner and Dr. Conroche. So I'm Guillermo Garcia-Manero from the Department of Leukemia at MD Anderson Cancer Center. And I share the enthusiasm about new approaches for patients with MDS. Right now, as Rami said, in those with lower risk disease.
So with that, let's get started. We all know anemia is an issue and problematic for patients with lower risk MDS. Let's start with you, Dr. Brunner. Can you tell us a little bit about these new data around luspatercept and where does that fit into the standard of care and how it relates to both transfusion dependence as well as the ESAs, the erythropoietin stimulating agents?
Absolutely. 2023, as mentioned, was really a breakout year for the development of new therapeutics in low-risk MDS. And one such area is how to deal with the first-line therapy for patients who have low-risk MDS and have transfusion needs. And this summer, the COMMAND study presented data comparing luspatercept head-to-head with ESAs in the frontline setting for patients. And this is really the first time that ESAs alone have really been unseated as the first-line treatment. For so many of our patients, we have used these for decades really as the first and sometimes only therapy that they would receive in their MDS journey. I think that the COMMANDS data provides really important evidence that starting luspatercept early when people are starting to have transfusion needs can really improve upon the chance of response as well as the duration of response. Now, there are certain groups of patients who might benefit even more than other groups, but overall, I think this is a real step forward in our disease space and provides a really compelling new therapy that allows us to improve on transfusion needs quickly in patients.
Fantastic. And Dr. Kamrachi, I know you've published actually specifically in this space as well around some of the kind of nuances around the data and particularly and potentially some of the kind of patient subsets and how the data worked out in those different patient types. Can you speak to a little bit about your insights on those data?
Right. So in particular to luspatercept?
Yes.
Yeah, so obviously, the original approval for luspatercept was for patients with ring sideroblast after ESA failure. The COMMANDS moved that up front, as Andrew mentioned, in intent to treat. There was doubling of the response, doubling of the duration. When you start looking at subsets, we see probably a little bit more benefit for certain subsets. So definitely the SF3B1, the RS positive. What was important for me is learning that patients that had EPO level above 200 really had a very low chance of response to ESA, like 12%. I think the controversy or the discussion is really, should we treat all comers with luspa or restrict that to the group that had more benefit? So for example, the study was enriched with RS positive patients, so 60 to 70% were RS positive. There were like 40 some patients on each arm RS negative, and the responses there were the same, probably a little bit longer duration of response with luspa. But the question, should we use that for all comers or not? I think that we need to tease out because we don't have also data on like use of ESA after luspatercept. But for me, I think definitely the RS positive seems really very appealing approach to double the responses, double the duration. In the RS negative, maybe we'll select some patients. If I see EPO level more than 200, that probably would make me think of luspatercept. And we still have to see a little bit more data in my mind in the other subset of RS negative.
I agree both with Dr. Brunner and Dr. Conrocky. We have a new, well, not really a new agent. We have a new indication for a drug approved a couple of years ago for low-risk MDS. The way the study was designed was really not specifically asking specific subsets, or so overall the data is very positive with doubling of response, very significant duration of response, actually almost a year. And actually the response criteria was quite powerful because we're talking about increased hemoglobin and the period of transfusion dependency. But Dr. Conrocky is totally correct. We need to learn more. We need to really understand who may or may not really benefit from this indication. But right now, I personally will take this data from the intent to treat angle. And I think this is a really very important discovery for our patients with lower risk MDS.
And Dr. Brunner, I know we talked earlier a little bit too about the data and how it relates to decreasing transfusion burden, as well as some of those other endpoints. Can you speak to a little bit about what those data mean and then why that can be impactful for patients kind of long term?
Patients with lower risk MDS, the primary symptom that they have and the primary clinical need that they have is recurrent red cell transfusion needs. And over time, that transfusion need will increase and results in heart, liver, other organ complications eventually, if just transfused alone. I think that we had not had a lot of options to alleviate that transfusion need in the past. And the big story coming out this year is that there are more options and that you shouldn't just settle on red cell transfusions lifelong for patients. In particular, our treatment options seem to work better when transfusion burden is lower. And so initiating therapy when patients have started to develop transfusion needs, rather than to allow them to accumulate complications of red cell transfusions, I think is the other big message that we've learned from these agents. So overall, I view this as having an expanded repertoire of active therapies in this disease. We all have to work with our patients to identify what burden they're having from their disease, but we have a lot more ways to reduce their transfusion needs than were available in the past.
Anything to add, Rami, as well? We talked earlier about the imetelstat. I'd like to get your thoughts on where the treatment for luspatercept, what's the future hold, and what's the current clinical trials ongoing to kind of tweak out where we should be using it most ideally, and then what are some of the other trials that are currently investigating, and what are they investigating at what patient stage of the disease journey, and what types of patients?
Right. No, so I agree at first with Andrew that I think, obviously we are making progress, and we should not be waiting our patients to be heavily transfusion dependent before we introduce treatment, because we have option. I think there's cumulative evidence that we've known for many years that patients that are transfusion dependent don't do well, whether that's disease biology or complications, as Andrew mentioned, of the transfusions themselves. And there had been this theme looking at like transfusion independency with correlation with better outcomes. We saw this from studies that looked at lenalidomide in the past. We saw this recently from studies from the medalists that patients that responded have better outcome. So I think the key message I would get out there is like we should not wait for our patients to be heavily transfusion dependent. Once they have symptomatic anemia or starting to use blood transfusions, we should be intervening or thinking of shifting therapies at that point. I think luspatercept is a great up movement. I think the appeal that it's easily administered every 3 weeks, relatively low toxicity, and effective treatment, especially if used in patients that are not highly transfusion dependent. And I think it's going to move up in the front, whether to replace ESA completely in all subtypes of MDS or in a major number of patients. but obviously there will be always some unmet needs after luspatercept. So where things are moving with luspatercept, actually moving them a little bit earlier. So there is a planned study called The Element, which will look at patients that are not transfusion dependent. And then there are also efforts on the other side to combine it with erythroid stimulating agents, because both of them mechanistically work on different stages of erythropoiesis. So we'll see more data in moving earlier or moving in combination. As you mentioned, there are other drugs in development, and probably the one that finished phase 3 and had a positive phase 3 and will be in front of the FDA for approval early next year is Emtilistat. I think that will be probably a second line, predominantly for patients with anemia, particularly high transfusion burden patients. So the drug in phase 3 showed a promising activity of, almost 1/3 of the patients becoming transfusion dependent for over a year, particularly in patients that are highly transfusion dependent. Early also signs of maybe reduction in the allele burden of some mutations, cytogenetic responses, but it comes with myelosuppression, grade 3/4 thrombocytopenia, neutropenia, fortunately not associated with risk of febrile neutropenia. So I think that will be added to our options, but I don't think it's going to be our first line. I think we're going to be moving with drugs like luspatercept. There are drugs similar in the TGF-beta family. There's a compound called KAR05 that's also moving in that area. So those will be our first line. Drugs like Emtilistat will be in our second line option.
So does anyone else have any last thoughts that they believe would be important for our podcast audience to know about? I'll kind of just throw it out to the group.
I think just the notion, as we mentioned, is just to move to treatment earlier a little bit. Don't wait for the patient to be highly transfusion dependent. And I think Andrew briefly touched on this point, that for a long time, actually, patient did not get any treatment other than ESA. We looked into a registry called the MDS Connect registry that captures data. Even patients that were moderate and severe anemia, sometimes were just on observation. A lot of the patients, only got ESA, and I think now we have other options, that we should not be settling for transfusion dependency as the only option or thing we can help our patients with.
Okay.
I agree with this, and I think you hear a lot of enthusiasm from Dr. Brunner, Dr. Komrokji. I think this is going to go step by step. We have new indication for luspatercept. I think, as Rami says, this will probably be used for a majority of our patients in the front line, just because, I think in the community, really making this distinction, the patient is RS positive, RS negative, this is actually not really practical. That's something that we have not really discussed this. And then we heard that we have coming good second options, but I think Rami said something very important, that is the combinations, because I don't think we need to go and rest, because now we have 60% response rate in first-line low-risk MDS. I think we need to become more ambitious, more greedy, if you will, and say, well, can we do this 100%? And indeed, Rami mentioned those data with low-dose lenalidomide and del(5q) that actually is giving them responses that are extremely high. So could we replicate that with some combination? So I think that, non-toxic approaches, as he mentioned, ESA plus luspatercept, because they work in different points of erythropoiesis, or lenalidomide, or actually maybe some new other drug that comes out of nowhere, just because we don't fully understand yet how luspatercept works, right? So we may find drugs that synergize with this. I think actually in the future, we will be, not in a distant future, in the near future, we'll be in a situation where perhaps combination could give us 100% hematological response rate. And again, Rami has presented data that those responding patients live more. And we saw some of this actually with the iron chelation studies, right? Like if you started improving on the kind of like end organ damage that is related to transfusions, patients have less cardiac toxicity, hepatic toxicity, etc. That I think will translate into better survival. And in addition, what Andy said, perhaps actually the early treatment, either with the single agents or in combinations, will totally abrogate transfusions in this group of patients. I think it's going to be very fascinating to see over the next few years what happens. And, it's going to take a little bit of time, because we have these ESAs with us for like 30 years or so, really without formal approvals, but wonderful drugs that really help us a lot. But now we're starting a new dimension. I see a little bit of inertia, like we've done this for so many years. Is this so good or not? But little by little, actually, this will be replaced. And the question is, what's going to happen to the disease itself if we start attacking it earlier? We have not discussed high-risk clonal of unknown significance, for instance. That's actually the next step here. It may be actually that the three of us need to look for a job at some point.
Yeah, no, it's a really exciting time, and while these are all developed with very specific indications in mind, they expand the number of therapies in MDS tremendously. And I would say that in contrast to therapies that are developed in maybe like AML, where therapies need to be a little bit more aggressive, a little bit more immediately active, most of the therapies that we're talking about are fairly low toxicity. Even imetelstat, we talk about some of the cytopenias, but the end complications from it are lower than a lot of therapies that we use in more advanced leukemias. I think a very interesting space to see, having more tolerable drugs does make it easier to give multiple lines of therapy, especially in older patients. Most of our MDS patients are in their 70s and 80s, and that's a real boon. B, as we learn about it in different spaces, you mentioned a little bit about higher risk MDS. If I've got an 85-year-old with quote unquote higher risk MDS, but just anemia, starting to explore some of these novel agents, first as trials, but eventually in different spaces in MDS really gives us a broader number of therapeutics for every patient that we see in our clinic.
Lots of great future conversations to be had.
Yeah,
So I'd also be remiss. I'd like to thank those of you who listened and watched this Expert Perspectives podcast. We hope that you found this discussion valuable to you, your practice, and the patients you treat. So bye from all of us. We'll see you next time.